what are the common ways now that you actually get on the diagnostic bandwagon here? Someone's in the office and says, I wheeze. Now what do you do? Let me guess you do a history
The
first.
history
he's
is the
already
most
done that.
important.
No, he didn't.
The
Well,
history
that's
is
because
the
he's
most
babbling about
important part
cytokines.
of diagnosis. And the most important part of the history in asthma or any chronic disease is the part we probably don't do as well as we should. Osler said it was the PPI. And I know you think PPI means something that we give when we have a little heartburn, but no. It's the patient's perception of illness and their goals of what therapy they have. So that history of asthma has to start there, and then it includes the history that gives you cough or wheeze or shortness of breath with the typical at night, and certainly asthma is a nighttime problem, night with exercise, with viral infections. You get the history. That you have to make a diagnosis, especially some of the things that John and I encounter every day, and Linda too, is that we have misdiagnoses. Some of the severe patients we see may not have asthma, or may have asthma and another complicating thing like vocal cord dysfunction. So the very first thing we have to do is make the correct diagnosis. We do that by history, number one.
Right.
Number two, we have objective tests. There's the spirometry Linda was talking about.
Before you even go to spirometry, you listen to the lungs?
No.
Oh,
Why
come
not?
on, you
Well,
listen to the
exam
lung.
is
after history.
no, exam in asthma oftentimes is very unrewarding.
Why is that?
Because oftentimes the most severe asthmatics with airflow obstruction don't wheeze, they may cough a little bit, they may not do anything. You can get a little bit of abnormality in the upper airway exam because it's kind of one airway, one disease, but the truth is the exam, you do it, and certainly it helps you rule out things, but oftentimes is not real helpful in making that definitive diagnosis. So Linda's right, in making the definitive diagnosis is a diagnosis of spirometry and giving a bronchodilator. And I would say even no matter what that FEV1, the amount of air you get out in 1 second, is, you need to give a bronchodilator and see how much it improves. And then you do these ancillary tests to try and typify the asthma if you're having a difficult time
What about
controlling.
pulmonary function tests?
Well, particularly in pediatrics, because they can have normal FEV1s, FVC, but when you go to reverse them, you'll see
Even in adults, we looked at several hundred patients at the University of athletes at the University of Wisconsin. And what we found was when we measured their lung function, it was quite high in the normal range. But many of them responded by over 15, 20% to a bronchodilator having supranormal lung function.
Let me ask very quick questions now. They're in the office, still in the office here.
Yeah.
Pulmonary function tests, you were talking about them. What about a chest x-ray, sinus x-rays? Useful, not useful?
Can be if the history suggests. And that's the thing. There's so many comorbidities.
not sinus x-rays, sinus CT scan. Nobody does x-rays.
There's so many comorbidities involved here. A lot of them we should probably talk about that really impact asthma and are super important for you as a payer. I know our HMO wanted to know what factor predicted next year who would give us the most problem with asthma, and we looked at about 90 factors over a 2-year period, and what we found it was a 2-question depression screen and PHQ-9 that we did that predicted. So depression, that was one of the first studies to show depression is really, really important in predicting
Another
asthma.
thing worth mentioning, there's a study by Aaron and colleagues in Canada. They looked at a group of people with poorly controlled asthma. They went to a specialist. You know what they found?
Tell me.
30% didn't
have asthma.
So I think some of the things we have to think about are that we can get hoodwinked. People that really look like they have asthma, or more importantly, their comorbidity is driving their asthma symptoms.
Are there biomarkers that help you make that diagnosis?
But
do they help identify that 30%?
But they only need to be used in those uncontrolled, difficult to control patients. They don't need to be used in every single patient.
So when do you use them? Who uses biomarkers? When do you use them? When do you get them?
Which biomarker are we talking about?
Take your pick.
Well,
I mean, you got
eosinophils.
cytokines, eosinophils, IL-4, IL-5,
super high
IL-13.
eosinophils, you start thinking about hypersensitivity pneumonitis or some of the other interstitial
But do you just
ones.
get them on everybody? What triggers the...
Almost everybody gets a CBC with
The
diff.
biomarkers we get are, we get skin testing to help us, and in a sense is a biomarker. It's illuminating that Th2 phenotype. So we get skin testing, then we get an eosinophil count, everything has to be value. It's got to be that quality over cost. So a CBC with differential, an eosinophil count, very valuable, extremely valuable. IgE level, valuable. Exhaled nitric oxide, a test that's relatively inexpensive, easy to do, reproducible. Oh, it isn't always useful, but it's useful a good bit of the time. And those are kind of the major biomarkers we're kind of left with today. We can't measure the cytokines, so those are the ones.
So what value were measuring eosinophils prior, and again, I'm talking from a pair, before the biologics were approved for eosinophilic asthma? What was the benefit of measuring
But we didn't have a
eosinophils?
stratifier. So in the past, if you think about it, we approached all asthmatics the same. And it's really contrary to the syndrome we've talked about, asthmas, I like that. And we would just basically put people on ICS and dial up to ICS plus long-acting bronchodilators. And when they failed, we would sort of scratch our head and figure out what comorbidity they had. Now, as we think about biologics, the present regime, the present options we have in our armamentarium are a T2 high phenotype. So we're looking at peripheral eosinophils. We're looking at skin testing, which we always looked at because that's a trigger. But we're looking at that more carefully, and we're looking at ENO and putting it all together and trying to predict the right person for the right
In
med.
the old days, we did eosinophil counts to see if the steroids were working. And I think that's an important thing. We're saying that eosinophil count is a biomarker. It really is more than that. It's it gives you the pharmacodynamics of the process that you're trying to interrupt. So if you give somebody an anti-eosinophilic treatment, whether it's steroids or biologic, the very first thing you can see is that eosinophil count going down. So at least it tells you that you're interrupting that physiologic process. Now, whether the patient gets better or not is something you have to say, but at least you know that you're interrupting the process.